We're going to get started. We have 4 speakers this morning, and we will take questions at the end if we have time. So I'm going to begin. My name is Sherry Cannon. I'm from the University of Alabama at Birmingham, and I'm going to be talking about the upper GI tract. All right, so specifically today, we're going to limit our discussion because of the time limit, just to talk about fluoroscopy. I think it's probably the area that has the most potential for misadventures, so we're going to limit it to fluoroscopy. And again, of the upper GI tract, we're going to talk a little bit about how to safely prescribe contrast agents in these patients. We're going to specifically review some of the postoperative anatomy. I think this is key because these studies really are not protocol driven. We have to answer 2 questions definitively. Is there a leak and is there obstruction? And that is our goal. And if we are unable to do that, 2 questions definitively. Is there a leak and is there obstruction? And that is our goal. And if we are unable to do that in our reports, we have really failed our surgeons. To be able to do that, you need to understand the anatomy because you need to know where to direct your images for leaks. We need to be able to recognize these complications. And also importantly, we need to avoid fluoroscopic pitfalls. So the most important thing I'm going to tell you today is this: clean up afterwards. And I don't mean that in the sense of clean up the room, although your technologists would probably appreciate that. I mean, when you have a patient like this, in this case, it's too tight of a lap band. There is a lot of residual contrast in the dilated pouch. If these patients are obtunded, particularly if they're obese, and if they're on a stretcher, you don't want to send them back to the floor with a full gastric pouch or a full esophagus. You really need to place a tube and drain this before you send them back to the floor. These patients are at high risk for aspiration, high volume aspiration, and it's a very difficult resuscitation. So we need to make sure that we don't leave our patients like this. So we're going to talk about a few principles of fluoroscopy because regardless of the surgery, these really apply across the board. The first one is, again, understand the surgical anatomy, and I can't stress that enough. This is not a procedure where you walk in the room and wing it. You need to know the specific anatomy. In fact, when I work with residents, I make them draw out the anatomy before they go into the room and point to me where the patient will leak from. I think that's important. We need to screen these patients just like we do when they roll into CT to get intravenous contrast. Most of these studies are going to be water-soluble contrast. They have the same risk profile as the intravenous contrast agents. We know that small volumes of these agents are resorbed across the GI mucosa. We know this is increased in post-operative patients, and we know that anaphylactoid reactions are not volume dependent, so these patients need to be screened. Really, each patient needs a scout image, and we'll talk more about this in a moment. And I recommend recording these as well. Sometimes you're able to capture information and you can go back and view the video recordings. I think this is very important because sometimes you get one specific moment, and if you don't capture that on the image, you may miss the opportunity to make a definitive diagnosis. And again, I think that should be the goal. If we give an equivocal report for our surgeons, we haven't helped them. All right, don't quit too soon. And what I mean by that is you need to have multiple views of the anastomoses. One view is no view, but also you need to make sure that the anastomoses are bathed in contrast and that at some point during the exam they are in the contrast pool. And you can't do this if the patient remains standing for the entire study or if they remain in a supine position. And of course, as with all imaging, you need to be aware of satisfaction of search. If you see one abnormality, push yourself to find additional abnormalities. So we're going to start with a total laryngectomy. Now in this case, this is a total laryngectomy with reconstruction via a radial forearm free flap. The surgeon takes a flap of skin from the forearm with the radial artery and draining vein and makes a neopharynx that's anastomosed near the base of the tongue and up in the cervical esophagus. So these are the areas where it will leak. It can also leak anywhere along the anterior portion because this is where the sutures are to make the neotube. Now, why is it important to get a scout image? Well, as you can see, these patients are complicated. They have surgical drains, they have vascular clips, they have skin staples. And in this case, it's probably not a big of an issue because in this view, you don't have a lot of overlap. But this is another patient, same surgery, total laryngectomy with a forearm free flap, and you can see vascular clips in the area that you're going to be looking for a leak. And it becomes problematic when sometimes you'll have a little bit of motion on an image and you may see a clip that's blurred a little bit, and then you're going to begin to equivocate. Could that be a leak? Is that a leak? So that's why it's helpful to have a scout image to go back and compare the clips that existed before you gave contrast. Don't quit too soon. We tend to want to get these patients in and out of our fluoro suite. They're sick, they hurt, they make us nervous. Tendency is to do the study as quickly as possible and get them out. You don't want to do that. Here's an example of you need to really focus on the history. This was actually a recent case of ours, not a postoperative, but a post-endoscopic. Was having dilatation of a distal esophageal stricture, post-procedure chest pain. Chest CT revealed pneumomediastinum. So this swallow was performed, and you can see contrast here that was thought to be pooling in the pharynx. And on the oblique view, and notice the oblique view where it's centered really on the upper thoracic and cervical esophagus. But we need to remember in these patients, endoscopic perforations typically happen higher in the pharynx, at the piriform sinus, or perhaps in the posterior hypopharynx, in a patient that has a cricopharyngeal bar or an osteophyte. So we just aren't centered high enough here. And this was reported out as pooled contrast in the pharynx and possible leak here. Well, in retrospect, what we're actually seeing, only this thin string of contrast is intraluminal. All of this is extraluminal, but we're missing the point of perforation because it's above the edge of the film. Now, this patient went to the OR, had debridement, was brought back the next day for a follow-up study, and these are select images from the digitally recorded study. You can see the initial swallow, and as contrast goes down into hypopharynx, we can see this large posterior leak that still exists. So again, you need to be sure to center on the areas of concern, so you have to be familiar with that anatomy. Another example of not quitting too soon, this is a similar patient, total laryngectomy. Initial images were only obtained in the upright position, and it looked pretty good, didn't see a leak. However, brought the patient back, laid him down in a supine oblique, and there's a huge leak here. So you've got to be really careful. You can't study these patients standing only. You need to, at some point, make sure they're lying on the fluoro table. This is a great example of satisfaction of search. This patient had no less than 7 swallowing studies over the course of the year. They had a total laryngectomy, and unfortunately a stricture developed at the upper anastomosis. This patient came in 7 times to have this stricture dilated endoscopically, and each time had a follow-up study to evaluate the stricture. And in this case, we even gave a tablet to prove that yes, it's still strictured. What was missed on all 7 studies was the fact that there was a tiny leak, unfortunately extending to this patient's bone graft in their cervical spine fusion. So you've got to be careful about the satisfaction of search. So let's move downhill a little bit and talk about an esophagectomy with a gastric pull-up. Now this can be done in several different ways. These are probably the 2 most common, the Ivor-Lewis, which is a right thoracotomy. Now this is often done with robotic surgery. Laparotomy is also performed so the stomach can be mobilized and pulled into the chest. Another approach is through the neck with a transhiatal esophagectomy and also a laparotomy. And there are pros and cons to both of these, but it's typically the surgeon's preference. And they typically postoperatively look about the same, except the transhiatals tend to have a little bit higher anastomosis. In general, you need to look at a few areas for leak. One is the oversewn edge of the gastric cardia. The most common site of a leak, though, is going to be at the esophagogastrostomy right here, and that's where nearly all of the leaks occur. You also need to interrogate the pylorus. Surgeons typically do a pyloromyotomy or a pyloroplasty, so we need to make sure that the stomach is emptying and there's no leak here. Our surgeons actually now inject Botox in the pylorus. So this is what a normal gastric pull-up looks like. Patent anastomosis, no leak. Gastric body is pulled into the chest, and remember, because they've been mobilized, they've been denervated, and they typically don't empty well. So this is a patient population that it's particularly important to make sure that you drain out the contrast before you send them back to the room if they're obtunded or if they came on a stretcher. Another example of don't quit too soon. Here's a patient that had a gastric pull-up, was studied on postoperative day 2, and found to have no leak. Patient was brought back 2 days later because the surgeon noticed increased drainage. And sure enough, we identified a leak here. In retrospect, you can see a peaked area here. It's hard to know if that would have leaked or not. Is it because they weren't rolled in enough positions? It's hard to know, but you need to make sure that at all points that all components of the anastomosis are bathed in contrast. Here's another example of a patient that looked normal, but only supine frontal views were obtained, and you can see the patent anastomosis here. Only when you rolled them into a fairly steep oblique could you see this anterior leak here. This is a different complication in a patient with gastric pull-up. This is a stricture at the anastomosis, and you can see the jet effect here as the contrast courses through the stricture, the proximal ballooning with the retained contrast. And finally, some of these patients, when they leak, as here at the anastomosis, it communicates with the airway, in this case the left mainstem bronchus, and you can see the contrast entering into the peripheral airways. This raises a concern. We have transitioned all of our upper GI studies to low osmolar contrast agents. We don't use gastrographin or gastroview because of the risk profile. In this case, if that would have been used, that would have been a high risk of acute pneumonitis. So for any of our studies, typically proximal to the ligament of Treitz, we use low osmolar agents. These leaks that communicate with the airway are typically treated with a covered stent placed by the endoscopist. We're often asked to evaluate these and make sure that the leak has sealed off. In this case, it did. We saw no more communication with the airway. But these stents are a little bit problematic because the distal end is not well seated in that gastric body, so it tends to move around. They often pass spontaneously into the stomach, and that's fine. They're retrieved. As in this case, here's another case which was, this was a different patient with a leak at the anastomosis, communicated with a bronchus on the right, you can see here. So a stent was placed. We saw no more communication with the airway. However, the patient was brought back because the stent had passed distally. The endoscopist removed it, and we brought them back to see if they had a leak. We saw this large ulcer in the stomach that was created by the stent eroding through that gastric wall. And unfortunately, they also still had a communication with the airway. So the endoscopist placed a second, slightly more proximal stent, and this patient did fine, but you can still see that large ulcer crater from the stent. So let's talk a little bit about reflux procedures, as they are incredibly common. This is a normal Nissen fundoplication, which is a complete 360-degree wrap. It should extend for about 3 to 4 centimeters around the gastroesophageal junction and be seated below the hemidiaphragm. Here's a normal Nissen as well, and you can see the fundoplication filling defect here in the fundus of the stomach. And again, it should extend for about 3 to 4 centimeters and be positioned below the diaphragm. This is also a normal toupee fundoplication, and what you notice here is contrast is actually extending into the wrap itself. That does not necessarily mean that the wrap has dehisced. It may simply reflect that the patient had been rolled into multiple obliquities, so don't be disturbed if you see wrap filling with contrast. Here's the patient with too tight of a wrap. You can see this narrow shoestring of contrast and the proximal pooling of contrast, and actually probably food from a few days gone by. This is the most common complication we see after fundoplication. Some people refer to this as a slipped wrap, where you see the wrap extending around the proximal stomach. It's too low because we see gastric folds extend well up into the chest. The gastroesophageal junction is here in the chest, and this patient has a short esophagus. In actuality, this is probably not a slipped wrap. It was probably an inappropriately placed wrap initially because of failure to diagnose the short esophagus. Another patient here, the wrap has mostly dehisced, but you can see it's clearly too low, extending around gastric folds. The GE junction is here as well into the chest, and this patient with a short esophagus. This patient has an intact wrap here, unfortunately is moved into the chest, and you can see the hiatus here as the pinch where the gastric folds cross the diaphragmatic crus. And finally, another example of satisfaction of search. This was a patient that had fundoplication surgery, was having recurrent chest fullness. The surgeon suspected that there was failure of the wrap, and sure enough, although the wrap was intact, and you can't really tell that here on this image, there was a recurrent hernia. But what was initially missed was this large gastric ulcer, probably the cause of the patient's symptoms, not the recurrent hernia. So let's move on to a little bit of bariatric surgery, and we'll start with the Roux-en-Y gastric bypass. These patients have a roughly 1 to 2 ounce pouch that is created from the stomach, the gastric cardia specifically. They have a blind roux limb here, and then the roux limb extends into the abdomen. Now, the places that we need to look for leak are here. The majority of the leaks do occur here, at least 75%. A small number occur here at the blind limb. And fortunately, very few leaks occur distally because this can be a difficult area to interrogate because of the overlapping bowel loops. This is a normal gastric bypass pouch, about 1 ounce. Here's the gastrojejunostomy. Again, this is the most important place to look for leak. Sometimes in the immediate postoperative period, you have edema, typically for 24, maybe 72 hours, and this resolves. This was a patient that had a little more edema than we typically see at the gastrojejunostomy, but this patient did fine. And then remember to look distally at the jejunojejunostomy. Now, in this case, it's easy to see because the patient actually had too short of a roux limb, but sometimes it is very difficult to identify this distal portion. But you don't want to quit too soon. You want to make sure that you feel the contrast has passed beyond this distal anastomosis. Here's another example of quitting too soon. Initially, this was thought to be the roux limb, and this was an underfilled blind portion of the roux limb. With additional contrast and additional repositioning, we actually realized this is the roux limb, this is the blind limb, and this is actually extraluminal leak. Now, what's important for us to determine is that leak into the residual gastric body, also referred by our surgeons as a gastrogastric fistula, or is it a free leak into the peritoneal cavity? This is key. If it's a free leak, they require immediate surgical intervention. If it's a gastrogastric fistula, the surgeons often sit on this and won't operate unless the patient has inadequate weight loss, and then they'll intervene. When we continued to reposition this patient, it was clear that this was spreading out under the hemidiaphragm and a free intraperitoneal leak. Now, here's an example of the gastrogastric fistula. You can see the pouch here, but you also see contrast filling another structure with gastric folds, and this is confirmed with emptying into the duodenum. So this is a gastrogastric fistula. And this is another patient, gastric pouch here. Here's the roux limb. Here's the blind roux limb. Extraluminal contrast was thought to be communicating into the gastric body, again a gastrogastric fistula. However, with repositioning and specifically placing the patient into an LPO position, you can see it freely spilling into the peritoneal cavity. So that's an important differentiator for us to make, and it's really not one that we can hedge on. Marginal ulcers are fairly common, and they're more often seen in patients who have too large of a pouch. They typically occur, as in this one, at the gastrojejunostomy. Another marginal ulcer here had an edema and a ball valve effect that was obstructing emptying of the blind limb of the pouch here. And here's another patient demonstrating a leak from the gastrojejunostomy, and again, the unexpected communication with the airway, emphasizing the importance of using low osmolar contrast agents in these patients. So let's close with a quick discussion on gastric band and then also on the gastric sleeve. So when we evaluate gastric bands, we look for the angle, the phi angle, as we see here. We draw a line through the spinous processes, a line through the thick portion of the band, and this angle should be roughly 4 to 58 degrees. And this is a normal appearance of the band. If the angle is different from that, it suggests a slipped band. Now, I can't remember those angles, so I do things simple. I look for the placement roughly at the 2 to 8 o'clock position on a clock, as in this one. This is a normal appearance. Another normal angle here, slightly flatter, but still within the range of normal. And the contrast as it courses through the band should be about 3 to 4 millimeters in caliber, as we see here. This is a normal appearance. Now, this person has a lap band, but you don't know it because, unfortunately, a protocol upper GI study was performed, which is not helpful in this case. You don't need to perform a double contrast study because it precludes you from adequately evaluating emptying across the band. That's why it's important we obtain good history to start so we can do the appropriate exam. This is a patient that demonstrates a band, the O sign, which is another finding of a slipped band. Instead of appearing as a bar, it looks more like an O. This is another patient that also has a partial O sign, but note the band is more than 2.4 centimeters below the hemidiaphragm, or twice the width of the band. That's another finding, and actually a more sensitive finding for slip band, and also an air fluid level in the proximal pouch. And that was confirmed with fluoroscopy in contrast, and you can see here the band has slipped distally, and you have proximal retention. This is another patient with the O sign of a slipped band that's completely obstructing the proximal dilated pouch. And another patient here, too tight. You can see this string-like contrast. In additional contrast, you can see a large pooling of contrast proximal to the band. And finally, this is a patient with a chronic, nearly obstructed band that's created a massively dilated pouch, and actually pseudoachalasia that you can see here on this CT scan because of the long-standing too tight of a band. And finally, this band was completely obstructed, as we see here. And we'll end with gastric sleeve. A gastric sleeve is tubularization of the stomach to decrease its capacity with resection of the greater curve. And these are the areas that we need to look here for leak. Again, we also need to confirm there's emptying across the duodenum. Now, the residual gastric sleeve may have some bizarre appearances, but the most important thing for us to tell the surgeon is, one, there is no leak, and two, that there is emptying into the duodenum. Now, leaks in gastric sleeves tend to be massive, and in this case, you can see this huge leak, this extraluminal contrast on the CT scan. So with that, hopefully we've visited some of the surgeries that you will see in the upper GI tract. You have a better understanding of how to safely prescribe the contrast agents for these patients and diagnose their complications. With that, I'm going to hand it over to my friend, Dr. Eric Paulson, who's going to talk about the postoperative pancreas.
Thank you very much, Dr. Sherry Cannon, and it's a delight and a true pleasure to have an opportunity to present to the RSNA, and I'm appreciative of the RSNA for inviting me to give or to participate in this session. So I'm going to talk about imaging the postoperative pancreas. And let me tell you that this talk is based on material at my institution, which is Duke University, also based on knowledge and images borrowed from a review article written by Kumar Chandrasekaran from the University of Indiana, as well as from Dr. Morgan at the University of Alabama. As you know, pancreatic diseases are complicated and difficult, and the pancreatic surgeries are complicated and difficult. Pancreatic resection is really the only way to impart a significant survival benefit or possible cure in patients with adenocarcinoma, and is occasionally used in the management of patients with chronic pancreatitis. In patients with pancreatic duct obstruction and chronic pancreatitis and chronic pain, pancreatic duct drain procedures are sometimes used. I'm going to talk about the postoperative appearance of both of those. I'm not going to talk about either autologous or whole organ pancreatic transplantation. In the early postoperative setting, we use CT to detect complications, and frankly, in the more remote postoperative setting, when looking for recurrent disease or restaging, we use CT as well. We use MR when the question has to do with the integrity of the biliary anastomosis, and sometimes use an hepatobiliary agent. Hardly ever use fluoroscopy in the setting of these, in the setting of the postoperative pancreas, at least in our practice. Let me make a shout out to Dr. Alan Oldfather Whipple, who in the 1930s modernized pancreatic surgery developed a two-stage approach to pancreatic head resection. That's been modified since then, but that procedure, which is the most commonly performed pancreatic head procedure, carries his name. This is what the post-op Whipple anatomy looks like, and it's usually done for patients with tumors in the head of the pancreas, as in this case of an adenocarcinoma causing biliary and pancreatic duct dilatation. With this procedure, the pancreatic head and the tumor in its entirety, hopefully, is resected, but also resected is the duodenum, the gastric antrum, the pylorus, the proximal jejunum, the distal common bile duct, sometimes almost the entirety of the common bile duct. Gallbladder is resected, and lymph nodes will be sampled. A place where complications and recurrence occurs is the pancreatico-jejunal anastomosis. Sometimes we call that the Whipple anastomosis in our practice. And frankly, I think they're difficult to find. These are 3 different patients, 2 CTs, 1 MRs. You kind of find the residual pancreas, follow it up to something that looks like a loop of bowel, and that's where the anastomosis is going to be. Sometimes you get lucky and there's a pancreatic stent, which is often left by the surgeon to decrease the possibility of an early postoperative leak. And here is what that pancreatico-jejunal anastomosis might look like on an MR scan. On a coronal view, pancreatic parenchyma up to the pancreatico-jejunal anastomosis. This patient happened to have a postoperative portal vein thrombosis as well. The hepatico-jejunal anastomosis is also tricky to find. One of the reasons it's tricky to find is sometimes almost the entirety of the common bile duct is taken with this procedure. So what I do is I follow the residual common bile duct down to the jejunal loop, and at that junction, of course, is going to be the hepatico-jejunal, or sometimes called choledocho-jejunal anastomosis. MR lends itself to looking at those really nicely. Here's an MR, and you can see the pulled up loop of jejunum, the pancreatico-jejunostomy, and the hepatico-jejunostomy right there. These patients also undergo a gastrojejunostomy, and typically for the classic Whipple, the one that's done most commonly at our institution, this gastrojejunostomy lives in the left upper quadrant, near where you'd expect the gastric body to be, and this one happened to be filled with gas at that particular point in time. Another variant of the Whipple procedure, or a variant of the Whipple procedure, is called the pylorus sparing pancreatico-duodenectomy. That's also called the Longmire procedure by many pancreatic surgeons. This is a lot like the Whipple, except that the pylorus, the proximal duodenum, and gastric antrum are left intact. Pancreatic head is resected, duodenum is resected, proximal jejunum is resected, distal common bile duct is resected. Why might you leave the entire stomach in? Well, the theory here is that these patients have better GI function and therefore better nutrition and weight gain postoperatively. I don't know that that actually is true in practice, but that's the reason the Longmire variation was popularized. The difference between the post-op pylorus sparing surgery and the traditional classic Whipple is that the gastrojejunostomy, imaging-wise, tends to be on the right of midline because the entirety of the stomach is left intact. Whereas in the classic Whipple, the gastrojej is usually in the left side of the abdomen. Now, as these patients tend to be resected for ductal adenocarcinoma, and as ductal adenocarcinoma has a proclivity to encase arteries and veins, at some sites these procedures are performed with a vascular resection. That vascular resection is not done at all places. It's somewhat controversial, but some studies have shown that it imparts a survival benefit compared to a standard Whipple. So if there's a patient that's otherwise resectable but who might have some encasement of the portal vein, as in that particular case, there are some choices that a vascular surgeon can employ to make these patients completely resectable for cure. In general, the criteria for when this might apply has to do with 2 centimeters or less of contact with the superior mesenteric vein or the portal vein. Sometimes the surgeons will anticipate a Whipple based on preoperative imaging for cure, and will find peritoneal-based disease, microscopic disease, maybe find some positive lymph nodes that weren't anticipated preoperatively. And in that scenario, it doesn't make sense to do a full Whipple. That would be too morbid for a patient with that sort of prognosis, but particularly in patients who might have had preoperative clinical features to suggest gastric outlet obstruction, we'll go ahead and do a palliative gastrojejunostomy, which you see right here. Another pancreatic procedure, which is done less frequently in our institution, is a central pancreatectomy. Here, the central aspect of the gland is resected. It's generally reserved for tumors that are a little more indolent than ductal adenocarcinomas, such as neuroendocrine tumors or cystic neoplasms of the pancreas. A predicate of this procedure is to have enough pancreatic tail left behind to justify leaving it behind. And here's an example of a mucinous cystic neoplasm that underwent a central pancreatectomy. These patients, of course, have the central pancreatic gland resected with the tumor and have an anastomosis at the pancreatico-jejunal anastomosis and a jejunal anastomosis as well. They tend to have leaks. Sometimes you'll get leaks at this pancreatic duct anastomosis or transection site right there. Here's a postoperative example of a central pancreatectomy. Note the pancreatic tail, note the pancreatic head, but the central part of the gland is occupied by this pancreatico-jejunostomy, and the surgeons will often leave a little tag, a little windsock, a little bit of extra jejunum, and you can figure that out by the little surgical anastomosis right here left behind, and sometimes that can be a source of confusion, and sometimes that can mimic recurrent tumor. As I said, these patients are prone to leak, and here is a leak right here in a patient after a central pancreatectomy. One of the more straightforward, if any of these are straightforward, one of the more straightforward pancreatic surgeries is the distal pancreatectomy. Here, the ampulla doesn't need to be messed with, and that's where many of the problems from the Whipple, classic Whipple procedure occur. This is for lesions in the pancreatic tail, like this islet cell tumor right here. Pancreatic tail resections can be performed laparoscopically, and when the pancreatic tail lesion is larger, the spleen usually comes out. Sometimes it's possible to save the spleen in the splenic vein, and that's important for fighting infection in the future. And here's an example of the transection margin. Pancreatic tail is completely missing. This person also had their spleen resected when their pancreatic tail lesion was resected. What on first glance looks a little bit like the postoperative Whipple is actually the appearance after a total pancreatectomy. Here the entire gland is resected, and there is also resection of the antrum, duodenum, proximal jejunum, spleen, gallbladder, most of the common bile duct, and lymph nodes will be sampled as well. Why in the world would you do such a big procedure? In a subset of patients with chronic pancreatitis in whom it's not clear if the pain is from the head of the pancreas or the tail of the pancreas, sometimes those patients will undergo, for palliation, an entire complete pancreatectomy, total pancreatectomy. There are some patients who have multicentric neuroendocrine tumors where the whole gland needs to be resected. There are some patients with an extremely high risk for pancreatic adenocarcinoma, and preemptively those patients may undergo a total pancreatectomy. Haven't seen very many of these in our practice. Here's what one might look like. Pancreas is completely missing. Here is the hepatico-jejunostomy, or here is the jejunal loop right here, and here is the hepatico-jejunostomy right here. Note the gas in the biliary tree. First of all, it helps you identify where the anastomosis is, but also if there's gas in the biliary tree that's refluxed up through the loop of jejunum, that suggests the anastomosis is patent. Pretty good evidence for patency there. Another surgery that's increasingly performed is simple enucleation of the pancreas. This is an islet cell tumor right here. And in the kidneys, it's pretty, easy, relatively straightforward for a surgeon to wedge out and pop out a peripheral renal lesion. Same thing in the liver, not so in the pancreas. The pancreas doesn't like to be messed with. It's got a bunch of little side branches in it that can leak pancreatic juice, that can wreak all kinds of havoc. And after the enucleation of this particular lesion, which looks straightforward, this person wound up with a pancreatic side branch leak and needed a percutaneous drain of that procedure. By the way, surgeons are loath to go back in on these patients in the early preoperative setting and will do almost anything to manage them endoscopically or with time and antibiotics or with percutaneous drain. This now brings me to the pancreas drainage procedures. The classic one is the so-called Postoperative procedure, or the lateral pancreaticojejunostomy. Here, the patient has a chronically dilated pancreatic duct, usually with multiple strictures, a so-called chain of lakes appearance, may have stones in the pancreatic duct, and a loop of jejunum is excised, or a loop of jejunum has a longitudinal transection within it that is laid over the pancreatic duct in a fashion such as this. So these patients tend to have a pancreatic duct that's dilated up to about 7 millimeters, and the loop of jejunum will drain this dilated pancreatic duct. The idea is that that will cure their pain. Doesn't always work. They'll ask postoperatively, is that pusto-anastomosis intact? Is that pancreatico-jejunal anastomosis intact? And all you can do is infer that it's intact and working if the pancreatic duct is not dilated. Here are a bunch of little stones, but the pancreatic duct is now being drained nicely into that pulled up loop of jejunum. A sort of cousin operation to the pusto that is reserved for patients with chronic pancreatitis in the head and unrelenting pain is the Becker procedure, similar to a Whipple, but the head is taken and drained, the remainder of the pancreas is drained into a pancreaticojejunostomy. The idea here is for pain relief. So these are done in patients who have head-dominant chronic pancreatitis without a dilated duct. The dilated duct patients tend to undergo a Whipple procedure, and I'm sure that the approaches vary from institution to institution and country to country. A few words about complications, because these patients are prone to complications in the early postoperative setting and are prone to recurrent disease in the more remote postoperative setting. So let me talk about some of the complications. First of all, in the early postoperative period, there's lots of things left over by the surgeon. You may see pancreatic stents like this one. Those are designed to keep those anastomoses intact and decrease the likelihood of a leak, and they often fall out, and it's not that big of a deal if they fall out. And you'll see surgically placed drains, and you'll see clips in the porta hepatis GI anastomosis staples in these patients as well. The pancreatico-jejunal limb, or the Whipple limb, or the pulled up loop of jejunum, whatever language you like, can be quite variable. This is the same patient, two different series in the same CT scan. Here the loop had collapsed. Here it had filled up with gas and fluid. It can mimic an abscess. It can mimic recurrent tumor. It can be confusing to figure out. It's particularly confusing if you have learners in your practice. Postoperative fluid is the norm after pancreatic surgery. I think a lot of patients after pancreatic surgery also have evidence of a little bit of leak in this postoperative fluid from one of the anastomoses. So you'll see fluid around the surgical site, in the free intraperitoneal space, and in the fascial planes. In fact, 30 to 50% of patients early on after a Whipple, like in the first week or 10 days, are going to have a significant amount of postoperative fluid. It's really a normal finding. What you worry about in the Whipple, and what's a contributor to the significant morbidity of a Whipple procedure, is a pancreatic duct leak, which is shown right here. In fact, pancreatic duct leaks in various series occur in 15 to 20% of these patients. And it has to do with the fact that the pancreas is hard to sew, doesn't take stitches well. It's tougher to sew than like a loop of GI tract is. It's particularly if it's a normal gland. If it's a chronically inflamed gland, and is more like a piece of leather, the surgeons can sew into it just fine. But if it's a normal pancreas with a tumor adjacent to it, that normal pancreas is difficult to put a stitch in, apparently. One of the things that'll be the clue to a leak is a surgeon will send the fluid coming out of their drains for amylase, and if it's amylase rich, that implies that the Whipple anastomosis is leaking. And generally, those patients will not go back to surgery because the surgeon can't do much. They will simply manage those patients in some other fashion. Here's one where a pancreatic duct leak turned into a fluid collection that was approached in this case endoscopically, and there you can see the guide wire and a nice post-procedure result right there in a patient who had a pancreatic tail resection. Here is a patient with a dual energy CT acquisition from our practice. This is the iodine, so-called iodine-only image, which shows very nicely this vividly enhancing mass in the pancreatic head, which of course is going to be an islet cell tumor of the pancreas. Looks like a straightforward resection, but post-operatively this person looked like this. Lots of loculated fluid collections. These collections had not only pancreatic fluid, but bile as well. And in our institution, we approach those percutaneously all the time. In fact, one of our fellows a few years ago looked at our experience at Duke University, and about 1 in 5 patients required some kind of percutaneous intervention, sometimes just an aspiration, in the patient after a Whipple procedure. Hemorrhage doesn't occur very often, does not occur very often, but it can occur. I think hemorrhage is more likely to occur in the patient who's had pre-existing chronic pancreatitis because their blood vessels are more fragile than patients who haven't had that. And here's a hemorrhage with some active extravasation within it. And here's a post-op fluid collection with some gas bubbles, obviously suggesting the presence of an abscess. In our practice, those patients would come right on down for a percutaneous drainage procedure. Some sites will approach these patients surgically. Here's a surgically placed cyst gastrostomy, and I show this just to point out that the peripancreatic cyst after a cyst gastrostomy fills up with gas and debris from the stomach, and they always look nasty, they look bizarre, they look like they ought to be infected, but if the cyst gastrostomy is patent, they're not. That's simply just expected post-operative appearance, and they will heal in like this one did over time. They don't heal into complete normal, but they heal in pretty nicely like this one did over time. Here's a patient who had a cystic tumor, sort of a unilocular, not otherwise specified cyst in the uncinate process of the pancreas. Looks like it ought to be a straightforward procedure and what's probably a fairly benign tumor, but post-operatively there was a disaster with GI leak and massive free intraperitoneal air, bowel ischemia, pneumatosis, and all sorts of complications. Doesn't happen very often, but it can occur. Here is one borrowed from the literature of a person who had a lateral segment liver infarction after pancreatic surgery. Again, doesn't happen very often, but did in this particular case. Post-operatively and remotely, these patients struggle with nutrition. They often wind up with chronic fatty infiltration of their liver. As you see in this particular case, they're also prone to other complications. Here's a pseudocyst which was picking off the pancreatic duct, causing obstruction of the pancreatic duct, and could be drained either percutaneously or endoscopically, depending upon your preference. These patients are at risk for recurrent tumor. One of the places to look is in the region of the Whipple anastomosis at the resection margin. Look for early metastatic disease in the liver in these patients. Look for vascular encasement. Look for evidence of peritoneal carcinomatosis, here characterized by the peritoneal thickening and infiltration of the gastrocolic ligament. Here's a patient with advanced metastatic disease following pancreatic surgery, huge tumor growing into the porta hepatis, a stent within a stent, biliary dilatation, probably a portal vein thrombus in there somewhere, end stage metastatic disease after a Whipple. So in summary, the post-operative anatomy in these patients is a little confusing, a little difficult to remember, and there are variations in approach from institution to institution and country to country, I suspect. The roux limbs or the hepaticojejunostomy loops or the pancreaticojejunostomy loops often fail to fill with oral contrast, so if you try to use oral contrast to identify those, that doesn't help very often. They may mimic an abscess or recurrent tumor as a result. I find it critical, as Dr. Cannon pointed out, critical to review operative notes and the medical record to try to figure out what a surgeon has done. Even if you do that, it can be difficult to figure out what a surgeon has done, and in the more remote setting, look very carefully for subtle recurrence. Thank you very much for your attention. Our next speaker is Dr. Philippe Soyer from Paris, France, and he's going to talk about the postoperative liver. Philippe.
Thank you, Eric. Thank you. So, good morning to everybody, and thank you for being here. During the next 20 minutes, I would like to become familiar with the expected appearances of the liver following surgery, and I would like to highlight the complementary role of the different imaging techniques in the diagnosis of postoperative complications. I would like you to become familiar with the imaging features of early and late complication, including recurrence of the initial disease, and I would like you to understand how the different imaging techniques are complementary for the diagnosis of complications and how they can help for management decision. Though this is organization of the presentation, we will start with a brief overview of the liver segmentation. After that, we will get through the different types of surgical resection. I will get through into the normal postoperative findings, and then I will show you some early postoperative complication. I will finish with the late postoperative complications. So the liver segmentation, as you know, is a three-dimensional concept, and this anatomy is based on the intrahepatic distribution of the portal branches and the hepatic veins. And as a landmark, you have the middle hepatic vein that divides the liver into right and left hemiliver, which were previously called American lobes. You know, some of you are familiar with the terminology, the American lobes, and I think it's more correct to use right and left liver or right and left hemilivers. And if each of these hemiliver is further divided by the right and the left hepatic vein into medial and lateral sections, and these sections were previously called segments when using the terminology of Goldsmith and Woodburn, which is probably more familiar to you. But again, it's more correct to use now sections instead of segments. And there are four sections: the right lateral, the right medial, the left medial, and the left lateral section. And each of these sections is divided into superior and inferior segments by an imaginary transverse plane, which is called the transverse caesura. Let's get through the different surgical types, resection, different types of surgical resections. Liver resections consist of anatomical resections and atypical resections. Anatomical resections are right or left hepatectomy, the sectionectomies, and the segmentectomies. And atypical resection are often complex resection, combination of different resection or wedge resection. This is a nomenclature that has been developed by the America's Hepato-Pancreato-Biliary Association, and I think it's very important to know this nomenclature and this description, because I think that the radiologist and the surgeon have to speak the same language. So when you talk about right hepatectomy, you perform a resection of the right hemiliver, that is a segment 5, 6, 7, and 8. And when you do a left hepatectomy, you remove the segment 2, 3, and 4. And the segment 4 can be further divided into a superior segment and inferior segment. This is an old description by Bismuth. And there is a superior segment, which is the 4A, and inferior segment, which is the 4B. Sectionectomies consist in resection of segments, and there are 4 sections that each of these contain 2 or 1 segment. And you have the right anterior section, the right posterior section, the left medial section, and the left lateral section. Segmentectomies can be done to remove a single segment, and sometimes you can combine 2 segmentectomies. That's called a bisegmentectomy. Atypical resection, this is an example of a wedge resection. This is done to remove a superficial tumor of the liver. So now let's get through the normal postoperative findings. They can be categorized into 3 groups. One can be considered as a surgeon trace. One consists of morphological changes, and one consists of fluid collection. One of the most evident, the most easily to identify postoperative findings is the presence of surgical metallic clips, and they are usually located at the resection margins. They are very easily identified on CT. Another postoperative finding in the presence of an epiploplasty. Epiploplasty is often performed after a right hepatectomy to fill the operative cavity. And in general, epiploplasty is located adjacent to the resection margins. It has a fat density attenuation and contains some internal vessels. Sometimes epiploplasty can be misleading, and it may mimic infected fluid collection, as in that case, the patient has a central hepatectomy, but you can differentiate between epiploplasty and a more critical complication, which is an abscess or a fluid collection. In that case, epiploplasty has no peripheral rim, no capsule, and the margins are pretty ill-defined. Vascular ligation, when the surgeon has used a metallic clip, can be visible on CT. And MDCT is also a nice tool to check for the correct placement of the surgical drains. They can be placed after a major resection usually, and they are left in place for 4 days. Sometimes they can be located in unexpected locations, so you have to check all the examination to check for the correct placement of the drains. The other group of postoperative findings consist of organ displacement. This is a result of the basic concept of oral vacui, and when you remove portion of the liver, other organs want to fill the empty cavity, and can be the colon, can be the stomach, can be the pylorus, as in that case. The kidney can move upstairs to be a little bit higher than usual, and sometimes the colon, after a major resection, can be located between the liver and the abdominal wall. Sometimes organ displacement can be confusing. This is a case of a patient who had a left hepatectomy, and the stomach came close to the liver, and if you are not very confident with the diagnosis of organ displacement, you can repeat the examination and make a repeat examination after oral administration of contrast or water, just to make sure that it actually the stomach and not an abscess. Another group of normal postoperative findings is the hypertrophy of the remaining liver. You know that after resection, there is a considerable increase in liver volume, and this has this can be visible on CT scan. Usually the patient with the greatest enlargement of the remaining liver had patients who had a combination of preoperative portal vein embolization and extended or right hepatectomy or extended right hepatectomy. And this is the case of a patient who had a major increase in the remaining liver volume after right hepatectomy. and also this is an accompanying enlarged left hepatic artery. This is a typical feature of the remaining liver after extended right hepatectomy. The remaining liver, this is a left lateral section, has a round shape, and this is clearly visible on this coronal view. Sometimes the remaining liver has not a rounded shape, it can be elongated, but it's just a variation, it has no impact of the outcome. Finally, a normal postoperative finding, which is very frequent and almost constant, is the presence of fluid collection at the resection margins. Usually, fluid collection disappear within 4 or 10 days, and usually there is a progression in volume reduction. And in that case, the patient had the remaining fluid collection with bubble inside. So in such cases, you have to change the drains. And this was because the drain did not work properly, because there was a kinking of the drain. So if you have a persisting fluid collection, I advise you to change the drain. Fluid collection can be limited. In that case, this is a patient who had a wedge resection and there is a small fluid collection at the operative site. Fluid collection sometimes can be misleading. This is a recent case we had, and we were very concerned about this fluid collection with gas bubble inside, and unfortunately the patient had fever too, so we did direct puncture of the fluid collection. There was no pus, no germs, nothing, and we went through the operative report and we observed that the surgeon used an hemostatic agent. It was Surgisol in that case, and it is very important to know the type of resection and look through the operative data to make sure that the patient had actually a simple procedure, and it's very important to make the interpretation of the examination with knowledge of what has been done during surgery to avoid unnecessary procedures. This is a case that shows the natural history of fluid collection. You see that it disappears with time, and usually there is a fibrous filtration at the resection margins. Now we will get through the early postoperative complications. Postoperative complication consists of fluid collection, thrombosis, and biliary injury. Arterial injury after liver resection is less frequent. It's more often observed after orthotopic liver transplantation. Fluid collection are predominantly located adjacent to resection margins. Most of them are seromas and hematomas, and less frequently biomas and infected collection, but sometimes you have to look at the diaphragm and check for subphrenic collection, which are not rare. For the diagnosis of fluid collection, we suggest that MDCT should be preferred because it has higher degrees of specificity for fluid characterization compared to sonography. And this is a case of postoperative hematoma. The blood is hyperattenuating, and MDCT is an useful examination to check for the decrease in the volume of the hematoma, and this is an indicator of favorable outcome. Sometimes fluid collection can be worrisome. This is a patient who had radiofrequency ablation and wedge resection for hepatic metastasis, and the patient had an infected hematoma. Infection was suggested by the presence of gas bubbles. MDCT helped perform fluid sampling, and then because there was pus and germs, the patient had a percutaneous drainage, and he felt much better after that. MDCT should be preferred also because it can depict active bleeding, and this is a case of a patient who had surgery and there was a substantial drop in hemoglobin level, and the patient had an active bleeding and he was treated by percutaneous embolization. MDCT should be preferred also for the analysis of fluid collection. Pleural effusion are a common findings after liver surgery, but it should regress and decrease with time. And in this patient, there was no decrease, there was rather an increase in the volume on the pleural effusion. So MDCT was performed and showed this communication, this fistula that was due to an intraoperative diaphragmatic injury. Thrombosis can be observed after liver resection. They are relatively rare after liver resection compared to orthotopic liver transplantation. And most frequently, thrombosis involves segmental portal branches or the remaining portal stump after liver resection. Hepatic vein thrombosis are usually observed adjacent to resection margins that can be considered as an acute Buerkeri syndrome, and sometimes it's a different type of hepatic vein occlusion. It's not a thrombosis, it's due to a kinking or a torsion of the hepatic vein after right hepatectomy. This is a very rare complication, but you have to think about and be aware of this potential complication because it's potentially life-threatening and the surgeon has to reoperate the patient very quickly. This is a case of a portal thrombosis of the right portal branch stump after a right hepatectomy. There is no specific treatment. It is an incidental finding, but you have to look at the portal vein, whatever. And this is another potential complication, which is a segmental portal vein thrombosis, which can be observed after a right hepatectomy. This patient had HCC and had a right hepatectomy, and he had segmental thrombosis visible on the postoperative CT scan. Portal thrombosis in some occasions can be complete. For sure, Doppler sonography is excellent at showing portal thrombosis, but CT is also a very good examination because it can show the thrombus has a hyperattenuating clot inside the portal vein, which is enlarged, and after injection there is a lack of enhancement of the portal vein and some perfusion abnormalities of the hepatic parenchyma. Thrombosis of the hepatic vein can be incomplete or complete. This is a case of incomplete thrombosis after hepatic resection. Biliary injury is not often visible after liver resection. It is observed in 4 to 5% of cases after major resection. And CT and MR imaging can show a non-specific fluid collection at the resection margin. Some authors use gadocetic acid because it has a biliary extraction, so you can see on MR leak with enhanced leak due to the leak of gadocetic acid after injection. This is a very good examination to confirm the biliary leak, but in our experience, the definite diagnosis of biliary leak is obtained with a direct biliary opacification, and when you do that, you can do in the same time a percutaneous treatment of the biliary leak using a covered stent. Sometimes you can observe some traumatic injury of the diaphragm, which was performed during the operation, and this may cause a kind of herniation of the small bowel through the diaphragm that can be responsible for small bowel occlusion, and MDCT is very helpful in that case because clinically it's very difficult to differentiate the ileus due to the use of anesthetic drugs and actual occlusion. And sometimes you have to manage some unexpected complication. For sure, this is a patient from another institution, and he was referred to us for the follow-up of treatment by radiofrequency ablation of this metastasis. And when we did the MR imaging, the patient had radiofrequency ablation of a wrong target. So it's a difficult case to manage because you have to talk to the surgeon and talk to the patient that he has to do something, a repeated treatment. Now we will finish with the late postoperative complications. Postoperative complication consists of initial disease recurrence, and sometimes when the surgery has been difficult, when interior injury has occurred, the patient may have ischemic cholangitis. Disease recurrence is best observed with MR imaging. We advocate the use of MR imaging for HCC, and we combine the T2 weighted imaging, the gadolinium enhanced imaging, and diffusion MR imaging. If you face patient with hypovascular metastasis, if you do CT, the best phase is the portal phase. You know, the portal phase is best as depicting hypovascular metastasis. And when you do MR imaging, we advocate the use of gadolinium enhanced phase and diffusion weighted imaging to best depict the metastasis. It's a specific case of hypervascular metastasis. This is a patient with a carcinoid tumor with intrahepatic metastasis of carcinoid tumors, and we believe that this metastasis, this specific type, is better depicted with diffusion weighted MR imaging. One thing to know, if you look at the liver for depicting recurrence, please don't look only at the liver, but look also to the entire abdomen. This is a patient who had resection for cholangiocarcinoma. He had the local recurrence at the anastomotic site. But if you look carefully at the examination, you see that the patient has also a nodule in the small bowel loop, and the patient ultimately had peritoneal carcinomatosis. Ischemic cholangitis can be seen on MDCT, but MRCP is usually much better for this diagnosis. This is a case of a patient who had the right hepatectomy, and follow-up MR imaging showed the association of bile duct dilatation and bile duct stenosis, which was consistent with ischemic cholangitis. So, as a conclusion, I'm a little bit late, I'm sorry about this, but it's a dense topic. It's very important to know the type of resection when you do your report, when you do your examination. It's very important to know what has actually been done, and it's important to know also if the surgeon has had some difficulties during surgery. Fluid collection usually in the majority of cases belong to normal findings, and early complications are predominantly abnormal fluid collections. Late complications are predominantly recurrence of the disease. And remember, look at the liver, but not only at the liver, and you must be careful and check for the vessel. Thank you very much for your attention.
Okay, for those of you who are staying with us, we are at the end of the GI tract now, and I'm going to review our imaging of the post-op colon. I'll start by reviewing a little bit of anatomy and what the surgery entails, and then from there we'll talk about how we image that. If any of you have been to colon cancer refresher courses during the week, you will have seen this slide. 50% of the Western population will develop a colorectal tumor by age 70. 10% of these will be a malignancy. In adult, colorectal cancer is the second leading cause of cancer death worldwide. So it's something that we look for and are involved with on a day-to-day basis. Just a little bit about colonic anatomy. Nice to remember that the colon slowly decreases in size as you go from ascending to rectum. The largest portion of the colon is going to be the cecum, and as you get towards rectum, it's going to decrease in caliber over the long course of the colon. It can be variable in length up to about 150 centimeters. There are 3 tinea coli, which are bands of longitudinal muscles, which will traverse the colon from the base of the appendix to the rectosigmoid junction. And this is a pictorial representation of the colon. Again, you can see that the cecum is the most capacious of all the areas or all the locations within the colon. A little bit about rectal anatomy, because this is going to become important as we talk about the rectal surgeries, and we go from there. As you remember, when the rectum transitioned to anus, we're at the dentate line. And this is an important area when we name a tumor, because if it's in the rectum, it's going to be of columnar epithelium, and it's going to be an adenocarcinoma, and in the anus, these are squamous carcinomas. You'll remember that the internal and external sphincter come in right just above the dentate line, and these are important structures. The internal sphincter is going to be the smooth muscle of the rectum. The external sphincters are going to be the levator muscle complex involved in the external sphincter, and these make up sphincter tone. So when the surgeon is deciding what operation will best suit the patient's malignancy resection, it has everything to do with its relationship to the sphincter complex. The rectum is 12 to 15 centimeters in length, and it does not have tinea, epiploic appendices, or haustra. This area is unique in the way the peritoneum has reflections around the rectum. The upper third of the peritoneum is going to be covered anteriorly and laterally. The middle third is just anteriorly covered, and then the lower third is entirely extraperitoneal, and you can see that here, anterolateral, just anterior, and now the structure is retroperitoneal, and that too is important when we think about the surgeries that are performed. Colonic resection is based on the anatomic location of the tumor, and they're named for the location of the tumor. So if the surgeon is going to remove a cecal or right colonic mass, it'll be a right hemicolectomy. Left hemicolectomy is going to include the splenic flexure through the sigmoid colon. If it's just the sigmoid colon, it's going to be a sigmoidectomy. You guys are used to seeing this terminology. It gets a little bit more confusing when we're talking about rectal tumors, but again, if you just remember where the tumor is in relation to the sphincter complex, that's how the tumor, or that's how the surgery is named. A low anterior resection is going to be when the tumor is above the sphincter complex. The surgeons will remove the tumor above and the perirectal soft tissues above the sphincter complex with the tumor in place. These patients, if advanced in disease prior to resection, will get neoadjuvant chemotherapy prior to surgery to shrink the tumor. These are T2 and T3 lesions, and then they will get either a coloanal anastomosis then, or a pouch will be created. Ultimately, they are going to have an intact coloanastomosis, so they will eventually have an intact sphincter complex, and stool will exit from below. A total mesorectal excision means they've taken out the rectum with the tumor and whatever is surrounding the rectum in the mesorectal, deep to the mesorectal fascia. So it's going to include the draining lymph nodes and the mesorectal fascia envelope. You need, depending on who you're reading, 1 to 3 millimeters of distance from either tumor or node to the mesorectal fascia line to make this a successful surgery. And again, these patients will eventually go on to some coloanal or pouch anastomosis. There are a couple things you have to remember. Again, this is a low anterior resection. The tumor is above the sphincter complex. The levator ani are showing where the sphincter complex is. So this portion of the colon is going to be resected. In doing so, the patient is going to have the splenic flexure freed up. If you're going to have a direct coloanal anastomosis, you need a bit of that length to be able to make that anastomosis. So not only will you see post-surgical changes here, but you'll see post-surgical changes in the left upper quadrant possibly. This is a pictorial representation of a pouch creation. They can be very funny in appearance. They aren't sort of classic, this is exactly what one looks like on every exam. So you have to be prepared for unusual appearances of pouches as you image these patients postoperatively. In the patient who has a rectal tumor that is at the sphincter complex or involves and is below the sphincter complex, the patient cannot have a sphincter preserving surgery. So the surgery, and this is an abdominoperineal resection, the surgeons will remove the tumor and block with everything surrounding it and remove the sphincter, and now the patient will require a permanent colostomy for fecal stream. And again, similar diagram, but here you can see that the tumor is at the sphincter complex. It's too low to keep rectal tone and preserve sphincter intact, so all of this will be removed and the patient will have a permanent colostomy. And then finally, when the whole pelvis is involved, the patient will undergo total pelvic exoneration. The tumor is removed with all of the pelvic organs. The patient will have a permanent colostomy and often a urinary diversion as well. These are the more morbid surgeries. These patients have a longer and prolonged course. The early postoperative period, we talk about it. I'm going to give you a definition as far as what the surgeons consider early postoperative period. It's usually within the first 30 days of the surgical procedure, and this is important because this is when adhesive disease and healing begins. Patients will begin to develop adhesive disease within 72 hours of the procedure. And over the next 2 weeks to 2 months, these adhesions will become very thick and vascular, and they will obliterate the natural planes. So it becomes very difficult to operate in that time period. Dr. Paulson said that the surgeons are loath to go in and re-anastomose a pancreatic leak. Our surgeons have a very similar feeling in the colorectal and small bowel arena because at this point these adhesions are very dense. Over past 2 months, the adhesions start to soften up and it becomes easier for the surgeons to go back in and do a resection, but they're very tentative about operating in the early postoperative period. We do a moderate amount of emergent luminal imaging, and we use water-soluble contrast. We're mostly looking for anastomotic breakdown. I will tell you that the majority of these patients will come to CT first. Non-emergent imaging in the colon or pouch, we do again with water-soluble contrast. We very seldom use barium in this patient population. And again, just like Dr. Cannon said, I can't emphasize enough that getting a scout radiograph over the anastomosis prior to beginning the procedure is essential. We have a lot of patients who come for evaluation of their pouch prior to ileocolonic reanastomosis or an ileostomy takedown, and we are looking for a leak. This patient has a suture line sitting right here that you can very faintly see on the scout radiograph. When you instill contrast, you get this sort of bizarre looking indentation here, and this was originally called a leak down here. This is in fact just a fold within the patient's pouch. The patient did fine, went on to ileostomy takedown, and has done fine since then. If you're imaging the patient with CT, the technique will vary significantly on what you want to know. I don't know how many of you are still using oral contrast routinely. My institution has given up oral contrast in routine imaging of the abdomen and pelvis, but we do like it in the setting of luminal imaging in a patient who are worried about a leak. We prefer to use intravenous contrast. Invariably, 2 to 3 patients a night come down with no oral, no IV, and those are complex cases that always happen after midnight. And then we do like to give an enteric contrast to look for an anastomotic leak. You are going to see pneumoperitoneum. It is some of these patients are going to be, or many of these patients now have their surgical resections laparoscopically, so they will have a little less air than the other patients, but you should be looking for air to resolve between 7 to 10 days post-op. You will also likely see an ileus in these patients immediately post-operatively. And this is expected to resolve in 2 to 3 days after their gut starts to wake up, and sigmoid motility really has a big impact on resolving the physiologic ileus. I will tell you that many institutions, including my own, are doing ERAS surgery, which is early recovery after surgery, so the patients leave the PACU, and begin on clears within the 24 hours of their surgery. So they are advancing these patients' diets very quickly, and the patients seem to do very well. Ileus obviously is characterized by diffuse distension of the small bowel and colon, and it generally resolves without anybody getting involved. This is characteristic pneumoperitoneum early on in a patient's postoperative course. The typical post-op changes that are normal are going to be fat stranding in the area of the surgical bed. Just like in all of these entities that we've imaged, there will be fat stranding, a little bit of hemorrhage maybe, and some simple fluid. If you start to see large volumes of fluid or air, you have to start thinking about an anastomotic leak. So this is a classic post-op patient. You can tell the patient's a little malnourished. There's a lot of anasarca, and there's a little bit of uncomplicated free fluid in the resection bed in the patient. This is normal. We see this all the time in the early post-op period. This is another patient with a little bit of simple fluid here. Here's some fat stranding from a right hemicolectomy. We see this all the time. We're all pretty prepared for that. In the pelvis, the imaging characteristics of a post-op pelvis are pretty traditional. Again, you're going to see a small amount of fluid or soft tissue in the presacral space. And the soft tissue is a combination of a lot of things. So number one, if these patients are going to get neoadjuvant chemotherapy or radiation therapy prior to their resection, they may have a bit of fibrosis down there, and that's going to add to some of that soft tissue in the presacral space. It is also a very steep area for the surgeon to dissect, so a lot of the dissection is blind, especially in a steep pelvis. So they're going to scrape a bit off of the presacral space, and that causes some hemorrhage and causes some granulation tissue in there. So that is a routine normal finding. What our job is to watch that finding and make sure it either stays stable or starts to regress. If you get more concave, it looks like it's resolving. It may never resolve, it may stay stable, and that's okay. What you don't want it to do is to start getting convex in borders, because you have to worry about tumor recurrence over time. So this is a patient preoperatively who had a low anterior resection. The tumor is here. And on the post-op image, you can see the evidence that a surgeon has been here, but you can also see a little bit of free fluid and some soft tissue thickening here in the presacral space. We see this all the time. This is a patient who, over time, you can see that soft tissue post-op has started to resolve, and it almost looks like you can't see it at all anymore. And this is the evolution of those changes. Like I said, it may not change, but you don't want it to get worse over time. This is a patient with a post-op hematoma. You can see here preoperatively. Post-op, you've got fluid within the abdomen and pelvis, but you have a nice hematocrit level here that lets you know that this is hemorrhage. We see this in this space. We don't get particularly worried about it. This, however, has a slightly more worrisome picture to it. This was a postoperative abscess in the presacral space. I'm going to talk about abscesses in a minute, but the thick rind around it, the more encapsulated appearance to it, should raise your suspicion of an abscess. Sorry about that. Postoperative complications, big one's going to be an anastomotic leak. The surgeons are always worried about this. There is a range in prevalence in the literature, somewhere between 3 and 10% really. The ileocolic anastomoses are sort of low risk for anastomotic leak, and the highest risk are going to be the coloanal. Again, pretty steep area, kind of blind area for the surgeon, and that places the patient at a slightly higher risk. Other risk factors include morbid obesity, steroid use, anything that will impair healing, so steroids or some other reason to be immune suppressed, malnutrition, so you've got malnutrition and obesity in the same patient, male gender as well, because the pelvis is steeper in the man, so it's a little bit harder anastomosis to perform and they're at higher risk, and then patients who bleed intraoperatively are at higher risk. And if you think about it, the surgeons sort of schematically split these patients into 3 categories. The asymptomatic patient is going to be someone who you happen to pick up a leak on routine follow-up imaging, and they're not bumping their labs, they're not complaining of symptoms. The subtle insidious patient insidious leak is going to be a patient who has failure to thrive in the early post-op window. You just can't get them to tolerate tube feeds. Their temperatures don't go down. They're kind of puny. And then the dramatic early leak, and we've all seen these patients are remarkably unwell when they come down for imaging. When you're looking for a leak, pneumoperitoneum and a fluid collection and extravasation of contrast is where the money is for diagnosing anastomotic leaks. We can see these on both CT and fluoro, but we do, again, mostly CT imaging. This is a patient who had a post-op right hemicolectomy, and you can see a ton of pneumoperitoneum and a ton of free fluid, and this patient was too many days post-op. This patient was about 2 weeks post-op and had an anastomotic leak. This is a serendipitous examination, KUB, after a fluoro examination. You see contrast spilling all throughout the peritoneal cavity. But the majority of the imaging we do looks like this. Here's a patient who had oral contrast, and you can see a frank anastomotic leak in an anatomic structure that doesn't exist. So this is just a fluid cavity that the patient has extravasated into. I promise you this is a different patient. Oral contrast didn't make it down to the anastomosis by the time we scanned the patient, but you can see air, fluid, flocculent debris in something that doesn't look anatomic. This was a patient who had an ileostomy takedown. You can still see the surgical drains, and the patient had a big leak. And these are the ones where hand-wringing begins, because again, they don't like to take patients back in the early postoperative period. It's a very hard abdomen to operate in, so some of our surgeons like to temporize these patients with drainage. This is a patient with a postoperative fistula, pre-op. This is post-op, and you can see enhancing margins of this fluid collections. This was an abscess, and my group does a ton of percutaneous drainage of these things. You can see our catheter in place, and the abscess is resolved, but the patient continued to come back with collections after the tube was removed. This is him at a different point in time. You can see that we're imaging the anastomosis, and this cavity freely fills with the drain in place. So this is a persistent fistula from a fluid collection. Abscesses are like abscesses everywhere. So they're well circumscribed, the margins will peripherally enhance, they may have flocculent air within it, and again, we routinely manage these with percutaneous drainage. This is a patient with an abscess in the right resection bed after a right hemicolectomy, and we put a drain in that. The answer is always we can put a drain in that, so we do. This is a patient who had an APR, so this patient should have nothing in this space, and you can see this well circumscribed encapsulated collection here with air within it. This was an abscess and it was drained. Small bowel obstruction in the early postoperative period. So first I'm going to talk about all comers. Typically these patients will present within the first 2 years, have colonic surgery. Within the first 2 years of surgery, 14% of patients will have a small bowel obstruction, which is a pretty amazing statistic if you think of all the people who have colonic resection, those who have it for diverticulitis and all sorts of other reasons. Most of these patients will not require surgery. In the early small bowel obstruction, and this is in that early postoperative period, we're talking about a couple days post-op, variable risk, 1 to 10% in the literature of people who present in the early post-op period. This is before they've been discharged even. And this is, again, a very dangerous window for reoperation. So these patients are often managed with nasogastric tubes for a prolonged period of time. And if they don't get better after 2 weeks of nasogastric decompression, then the surgeon is forced to go back operatively and take care of the patient. The one thing you want to exclude is that the patient has herniated bowel at a laparoscopic port site, because these do need to be repaired surgically. And this is a patient very soon after the original surgery, and you can see this is status post right hemicolectomy, and you've got a relatively high-grade small bowel obstruction. This patient did fine with nasogastric decompression. And then finally, our role in the postoperative patient is not only to look for complications, but to look for recurrence. And in the setting of colon cancer, tumors can recur extraluminally or intraluminally at the anastomosis. And then because of the unique nature of colon cancer and its proclivity to go both to the liver and lung, these patients will get a chest, abdomen, pelvis. In fact, the American Society for Clinical Oncology recommends a chest, abdomen, pelvis for the first 3 years postoperatively, and always include the chest because the lung is an equivalent anastomotic bed or a metastasis bed to the liver. So you don't want to exclude the chest when you're re-imaging these patients. The lung metastases, if singular, are more easily resectable than liver resections, as we learned. And so you really want to make sure you're very vigilant about this patient population. This is the National Comprehensive Cancer Network. If you ever wonder what their guidelines are, you can log on for free and become a member. And this is their guidelines for surveillance: chest, abdomen, pelvis annually for 3 to 5 years in patients for high risk for recurrence. PET scan is not routinely recommended. We've seen a very steep downturn in our PET imaging of this patient population, but we do a ton of CT imaging of these patients. MR is not our screening modality of choice. We are pretty committed to the CT form, and that is the recommended modality by the societies referring their patients to us. Again, variable appearance of colorectal metastases. You can have right along the anastomosis. This is an exophytic anastomosis. This is a patient who developed something in the presacral space in that bed. This is a patient who I'm not sure I would have picked up on the CT portion of this exam. It just became a little thickened just above the anastomotic margin, and this was a colorectal recurrence. This is a patient with a lung metastasis. They tend to be round and well circumscribed. And then this is the one that scares me. This is a patient back when we were doing more PET who had what looks like a sort of ill-defined low attenuation area just in the area you'd expect diaphragmatic slips, though. So very often you see these and you sort of excuse them for pieces, volume averaging of the diaphragm, but this actually ended up being a metastasis very high in the liver. This is a patient, again, we've got some PET imaging. Chronology is really important. We love old imaging because it's very helpful to watch tumor beds. This is post-resection, and you can see at the time, immediately post-op, patient had a normal adrenal. Now the patient no longer has a normal adrenal, and this was an adrenal metastasis. So chronology and being able to go back multiple prior imaging studies is really very helpful. So thank you, everybody. Hopefully in this time we've reviewed the anatomy and the surgical procedures, and I think all the speakers are now available for questions. If there are questions from the audience, we can do this informally or formally. Thank you.